Hello, I'm William Katowitz, and I'll be speaking today on the subject of pushed monocanalicular stents in lacrimal surgery, discussing specifically the Masterka, introducing you to the LacriJet. And I have no financial interest in any of the materials presented today and have no financial disclosures. Lacrimal stents can be both bi and monocanalicular in configuration and all have an effective place in lacrimal surgery. They can be used to treat congenital and acquired nasolacrimal duct obstructions. They can be used in canalicular laceration repairs as well as in DCR surgery. If you go to the FCI ophthalmics website, you can introduce to yourself some of the products that this company makes that are both mono and bicanalicular. And we'll be discussing specifically the Masterka as well as introducing you to the LacriJet. Now, the LacriJet is a wonderful development that is an expansion of the Masterka technology. It's a preloaded device for the insertion of a monocanalicular stent. And we'll be discussing that at the very end. Monocanalicular stents can be in the pulled or pushed form. The pulled stent, or specifically the Monica or self-threading Monica, or the Mono Crawford, requires an intranasal retrieval. And this maneuver can cause laryngospasm because of bleeding and often requires some form of airway anesthesia versus just masking, which can be accomplished with the Masterka or the LacriJet. To review the anatomy, you'll appreciate that some patients who have congenital nasolacrimal duct obstructions have a distal membrane versus others have a canalicular clearing but have a tightness or stenosis that is either mucosal or bony within the nasolacrimal duct. It's this bony stenosis that is somewhat more challenging and is really not correctly indicated for the Masterka, but in some settings of stenosis, the LacriJet can be used, which is why it is an improvement. So the push stents spare the intranasal retrieval, therefore less nose bleeding and less of a risk of laryngospasm. They can be accomplished with mask airway anesthesia or a Lindner mask airway. And it is simply a modification of the existing pulled stent or the Monica. And once again, this is just showing you the use of the self-threading monocanalicular stent with the use of a Rittling guide. And the Masterka is really a development that was made to spare that intranasal retriever. So what you see here is an introducer that is going into the lumen of a monocanalicular stent, and usually a 3 millimeter collarette at the punctal plug. The devices you need to perform this surgery are a sizer that allow you to estimate the size of the needed Masterka, as well as the actual introducer itself and the Masterka, and then finally a seating device so that the punctal plug and collarette can be seated properly into the eyelid punctum. This is courtesy of Bruno Faye, just showing you the use of that sizing device. And you want to confirm metal-metal contact to make sure there isn't a false passage, and in fact, there is patency of the system. And then this is just depicting intubation and maneuvering of the eyelid and confirming that the length is correct, as opposed to this, which is a stent that is not properly placed because it's too short. The one major difference between the Masterka and the LacriJet, despite the maneuvering of the removal of the introducer, is the fact that with the Masterka, you do need a second instrument to hold the punctal plug of the monocanalicular stent flush to the punctum when removing it. And this is just showing you that it's a back and forth clockwise and counterclockwise maneuver that allows for the removal of that metallic guide, and then finally the proper seating. Now, the use of a sizer is critical because you want to make sure that the length of the stent bridges the valve of Hasner. And this is just showing you the depiction of the placement of a Masterka and then holding that punctal plug of the Masterka and the collarette flush to the punctum upon retracting the insertion device, which is just a metallic guide, and then finally seating.
Hold your hand real quick.
And then this is just showing you a depiction of removing the stent.
Okay. Ready?
Which we perform with
One,
with a
2,
non-tooth adset.
3. Good job. That's it. There it is. This was in your eyelid. Thank you, Doctor.
So the really nice thing about the monocanalicular stents is they're very easy to remove in the office. And once again, I do it with a non-tooth forceps that comes in your typical suture removal kit. A few years back at an American Academy of Ophthalmology meeting, we presented our experience with the use of a push stent as compared to the pulled version. And the thing I really want to bring home is that we had very similar outcomes in terms of success rate. The technology itself has a collarette similar to that in the monocrawford as well as the other stents that are monocanalicular. And we updated our experience using the Masterka and showed actually less stent loss overall when compared to a large series by Bruno Faye, compared with stent loss of 4% to 12.5% with similar outcomes. The LacriJet is a device designed by Bruno Faye that is really an improvement in terms of the overall efficacy and surgical ease for the insertion of a monocanalicular stent in a pushed form without having to retrieve it from the nose. And we published our experience just recently, a year ago, and this is a video courtesy of Dr. Faye showing you the device. And what I really want to bring home is the idea that the very tip of it, the metallic guide, the stent is within that introducing metallic guide, whereas in the Masterka, the stent bridges over it. And what that does is it allows for somewhat of greater ease of intubating the stent in the tear system, especially in the setting of stenosis. So that metallic guide allows for, I think, a slightly better advancement of the stent at the lacrimal sac duct junction. And this is just depicting that metallic guide and showing you after removing the safety ring, then the sliding position by pulling back that it inserts the stent. And once again, this is just showing you the position of the stent that's housed within this metallic guide. And the maneuver really, I think, requires less manipulation and most importantly, does not require a second instrument that's necessary to keep the collarette and punctal plug of the stent flush to the punctum when disinserting the inserting device. Once again, this is just showing you how with bridging of the valve of Hasner and proper placement without the use of excessive manipulation of the eyelid. And this is courtesy of Bruno Faye, just depicting the use of the LacriJet, removing the safety ring, holding the LacriJet flush to the punctum, and slowly retracting the metallic guide by sliding the piston posteriorly, or retracting it rather, and allowing for proper insertion of the stent into the nasal space through the valve of Hasner, as it's depicted here with the endoscopic view, which, by the way, is not necessary in the surgery, but for the purpose of demonstration is why we have it here on a video. So Bruno asked us to help him publish his experience with the LacriJet initially. We've placed 37 stents in 25 patients. The average age in this pediatric population was 2.8 years with a follow-up of 17 weeks with an overall success of 90%. And early stent loss did occur in roughly 20% of cases, which is comparable to other monocanalicular series, with punctual seating or a loose stent occurring in 5 cases and only 1 case of intracanalicular migration. And this is a simple protocol just showing you that when probing in the OR and there's mucosal stenosis with good metal-metal contact, that push stent intubation with or without a laryngomask airway or a simple face mask is quite useful. And the LacriJet, I think, makes for a very smooth and quick insertion of a monocanalicular stent. So the advantage of the LacriJet is that it's easier to insert. It doesn't require a second instrument with an introducer for retraction, and it can be used to treat tear duct stenosis. It's effective in treating nasolacrimal duct obstructions, and it's possible in other applications such as DCR surgery and canalicular tear repairs. And I'd like to thank you for your patience today and for paying attention to our presentation. Have a great day.
Hello, everyone. As a matter of formality, my name is Reynaldo Javate. I'm an oculoplastic surgeon at the Lacrimal Orbital and Oculofacial Plastic Surgery Service at the University of Santo Tomas Hospital Eye Institute University of Santo Tomas Hospital, Manila, Philippines. Today, we're going to talk about updates on lacrimal stents, namely the Masterka and the LacriJet stents from FCI. Masterka is a monocanalicular silicone tube device with self-retaining punctal fixation. It consists of a single unit including a silicone tube with a punctal plug and an introducer. The punctal plug consists of three parts: a bulb intended to prevent the spontaneous extrusion of the tube, a neck which will be in contact with the meatus, and a collarette that will lay flush on the eyelid margin and prevent migration of the plug. The punctal plug appears to make room for a plug inserter. The metallic guide introducer is located inside the lumen, not as an extension of the stent as in conventional stents. Unlike the traditional pull technique in which the stent is advanced through the nasolacrimal system and retrieved through the nose by pulling on the guide probe or thread, the Masterka has no metallic probe or suture attached to it, and therefore it is not pulled out of the nose. Instead, the Masterka is pushed into the nasolacrimal duct and anchored in place at the punctum by a plug-like fixation head. These are the advantages of your Masterka. Easy to insert, no nasal retrieval, no knots nor sutures, less traumatic, it is shorter duration of surgery, minimize the risk of injury to the intacanalicus, and requires sizer to select length and disposable punctum dilator and plug inserter, and it is available in three lengths: 30, 35, and 14 millimeter. I use the Masterka silicone tube in patients with congenital nasolacrimal duct obstruction. Congenital nasolacrimal duct obstruction is a common condition causing excessive tearing or mucoid discharge from the eyes due to blockades of the nasolacrimal duct system. Nasolacrimal duct obstruction affects as many as 20% children aged less than 1 year worldwide and is often resolved without surgery. Available treatment options are conservative therapy, including observation, lacrimal sac massage, and antibiotics, and invasive therapy. The first-line invasive treatment in the management of congenital nasolacrimal duct obstruction consists of irrigation in conjunction with probing. The most favorable timing for probing remains controversial. Now, to alleviate persistent epiphora and mucus drainage that is refractory to probing, repeat probing, silicone tube intubation, balloon catheter dilatation, or dacryocystorainostomy can be considered as available treatment options. Other second-line strategies adopted in cases of probing failure, as I had mentioned, are your repeated probing and silicone intubation. Now, technique of probing of the nasolacrimal duct with Masterka. The Masterka silicone tube is inserted until it makes contact with the bone. Now, the introducer is then rotated in order to catheterize the lacrimal sac and the nasolacrimal passage. This movement is the same as that used in the exploration of the lacrimal passages. This movement positions the punctal plug in contact with the punctal opening. Now, removal of the introducer. The punctal plug should be firmly held against the punctal opening, while at the same time, the introducer is fully extracted from the hole in the tube while applying pressure on the cylindrical tube. Now, the punctal plug is then seated into the vertical canaliculus with the help of a plug inserter from FCI. The collarette should be firmly placed flushed against the eyelid margin. The plug neck should no longer be visible. Now, this video demonstrates 3D lacrimal surgery in removing the Masterka silicone stent in a patient with congenital nasolacrimal duct obstruction. This new system has remarkable teaching possibilities. Everyone in the operating room can follow the procedures step by step and becoming especially attractive for residents, fellows, and medical students. I also prefer the Masterka monocanalicular stent when there is obstruction present either in the upper or lower canaliculus. I performed microendoscopic canalicular trephination, or MCT, to pierce through and remove the obstruction before inserting the Masterka monocanalicular stent. Here's a short video of the procedure. So after microendoscopic canalicular trephination, the Masterka stent is inserted into the recanalized canaliculus down into the nasolacrimal duct. You push the Masterka into the nasolacrimal duct until the plug comes in contact with the punctum. Now, the plug must be firmly held in contact with the punctum during the removal of the metallic guide. Make sure to pull the metallic guide out along the main axis of the lacrimal duct. Now, you remove the metallic guide by rotating it back and forth during withdrawal. The plug must be seated in the punctum with the help of a punctum plug inserter. And once the plug is in place, the collar should rest flush against the eyelid margin. Now, the Masterka is also used in the repair of canalicular laceration. The intubation of lacerated canaliculi with Masterka tube for canalicular repair is simple, safe, and effective procedure. Suspicion is a key element in the diagnosis of canalicular injury. All lacerations involving the medial eyelid and medial canthal area should be presumed to involve the medial lacrimal drainage system until proven otherwise. Superficial injuries within 6 millimeter medial to the punctum can lacerate the canaliculus. The most definitive measure in diagnosis of canalicular laceration is through probing. Diagnosis is made by passage of a lacrimal probe through the punctum, and canalicular involvement is confirmed when the probe emerges from the lacerated end of the canaliculus. Now, here in this video, I use the Masterka silicone tube with punctal fixation stent in this 11-year-old male who had eyelid and canalicular laceration, right upper eyelid. Now, the Masterka is placed within the lumens of the canaliculi to bridge the lacerated areas. Monocanalicular stents minimize the risk of injury to the intact canaliculus compared to your bicanalicular silicone stent. Now, the Masterka needs no nasal recovery, thus making it a less traumatic procedure. And here's the pre-op and post-op picture of the patient 12 days post-operatively. Now, in acute laceration, it is easy to find the distal end of the canaliculus, but with difficulties to locate the proximal end of laceration. For this operation, I do the operation under the microscope. I use a microendoscope, which is passed through the lower canaliculus, which is the opposite of the injury site, up to the lacrimal sac, then rotated to place the tip closely adjacent to the proximal end of the lacerated canaliculus. Then the microscope light, or the light from the microscope, is dimmed to enable visualization of the light source in the lacrimal sac from the proximal lacerated point or port. Here's another pre and post-op picture of a 5-year-old patient with Masterka stent. LacriJet is FCI latest and exclusive preloaded and self-retaining monocanalicular nasolacrimal intubation indicated for epiphora from nasolacrimal duct obstruction and congenital nasolacrimal duct obstruction and canalicular laceration. It consists of a single-use injector handpiece into which a silicone tube is preloaded inside a metallic probe. LacriJet has been specifically designed to reduce operating time either in the intubation phase as well as for the removal of the device, and also to protect the silicone tube during intubation. LacriJet stent is a monocanalicular nasolacrimal stent, solid silicone tube with an external diameter of 0.64 millimeter with self-retaining punctal fixation preloaded into an injector to facilitate the introduction of the stent into place in the tear ducts. The LacriJet comes in 7 models: 15 millimeter, 20 millimeter, 30 millimeter, 35 millimeter, 40 millimeter, 45 millimeter, and 50 millimeter, depending on where you will use it. The LacriJet stent is used in cases of focal stenosis in nasolacrimal duct obstruction, and the LacriJet is first introduced into the nasolacrimal duct, and once in position, the sliding piston is retracted and the silicone intubation is released. It is maintained in place at the punctum by a plug-like fixation, and no nasal retrieval, no knot, and no sutures are needed. Here's the patient after transcanalicular endoscopic lacrimal duct recanalization with LacriJet monocanalicular stent in place 2 months after removal of the stent. Now, patient remained patent with irrigation with no reflux, positive functional endoscopic dye test with resolution of infection and epiphora with no recurrence of epiphora during the follow-up periods. Thank you and stay safe.